Hello again. I'm Dr. Hung Vu, and our show is America's Healthcare Crisis. For tonight's discussion, I'm very pleased to announce the participation of three excellent speakers who will talk to us about the two opposite aspects of healthcare: acute care in the emergency setting and the care of the chronic illness, such as hypertension, diabetes, including cancer. Our first speaker will be Dr. Carl Mango. How are you today?
Just fine.
Welcome to our show.
Thank you very much. Thank you for having me.
Dr. Mango is a specialist of emergency medicine. He was the past president of the American College of Emergency Physicians, and is also the co-founder of the Fisher-Mango Group in Pleasanton. He has a vast experience in both the clinical practice of emergency medicine as well as its organization and administration. He will be talking to us about acute care in the emergency setting. Dr. William Buckles is an internist oncologist. Hello. Welcome to our show. Dr. Susan Buckles is a PhD and is a clinical psychologist. The Buckles are a husband and wife team, and they are engaged in the practice of private practice in Los Altos of internal medicine and oncology. They will be talking to us about the care of the chronically ill patients. We will first start with Dr. Mango. Dr. Mango, what do you think about emergency medicine as it's being practiced nowadays?
Well, Dr. Vu, emergency medicine started about 31 years ago in sort of a formal discipline, and the degree that it's practiced today is incredibly improved. There are a large number of quality physicians in emergency medicine and quality nurses. Medicine, in my view, is an art, a science, and a business. The art is, of course, the interpersonal reaction or interaction. The science is the product, and the business is the medium of exchange and the method by which the environment and the context is delivered. On the other hand, while the clinical aspects have improved, the organizational and the management of emergency departments really still lag. Many of your viewers have been in emergency departments and have probably found them slow, expensive, noisy, crowded. This is, I think, an example of a systems failure. It doesn't have to be this way. I like to look at the emergency department as the microcosm of the hospital, only much faster. And I think a lot of the public evaluates the whole hospital by what they see in the emergency department. And in some hospitals, that's very good. And in most hospitals, it could be improved a whole lot.
Thank you very much for your knowledge of emergency medicine that you share with us tonight. Dr. Buckles, how is the care of the chronically ill patient is being practiced in our community?
I wear two hats, and one is as a internist and primary care doctor, and the other one is as a specialist. What's common to both is that my patients tend to have chronic diseases. In the emergency room where acute illnesses are found, the illness occurs, is treated, and goes away. Chronic illnesses like high blood pressure or cancer occur, may be treated or controlled, but always have the chance of coming back. So neither the doctor nor the patient can ignore these, and hence they are living with them forever. I also look at chronic illnesses as a system and a series of relationships. There is the doctor-patient relationship, the relationship between the owner of the body and the body, and the relationship between the person and the dis-ease. The doctor-patient relationship ideally is a dialogue where both parties talk to each other, not at each other, and both parties listen. There's trust, agreement on goals, agreement on what the problem is. The patient brings the problem as well as their own knowledge of themselves. The doctor brings his technological expertise and an objective ear. The relationship between the owner of the body and the body should be that of educated respect, a willingness to maintain and preserve the body. What is interesting to me in looking at the relationship of the dis-ease and the person is to understand the wound of cancer, which is very, very complex and is not simply the surgical incision, but the disruption in the person's lifestyle, the emotional response of anxiety, a confrontation of mortality, the damage it does to the relationship between the patient and his spouse. Ideally, the person will respond creatively and see that in this crisis, as in the Chinese word for crisis, Wei Ji, which is made up of the two ideograms, danger and opportunity, that they'll be able to respond to the danger constructively, but also find inherent in the crisis an opportunity for personal change, meaning, and an active involvement in their own health.
Thank you very much, Dr. Buckles. Dr. Susan Buckles, you must add such a dimension to the practice of your husband. I'm very interested in hearing what you have to say about your own experience with the care of the chronically ill patients.
Well, I am a clinical psychologist, but prior to getting my PhD, I was a physician's assistant. So I draw upon my knowledge of the body, about illness, and how treatments are used, and basically share that knowledge, help educate patients, and help to correct misconceptions they have when they're faced with a chronic illness. Frequently feel overwhelmed to have something that they might die from or might have forever. So a lot of my work is with educating patients. Frequently, our patients in this community are very well educated. They know they need to diet, they know they need to exercise, they know they need to reduce their stress. But for a variety of reasons, usually related to their past, they sabotage their own efforts. So my work with patients is to help untangle these knots. It might be a sense of unrealistic expectations, or someone doesn't know how to say no or set limits on themselves or someone else, or they simply don't know how to nurture themselves without either drinking too much or eating too much or smoking too much, so that they need to learn how to relieve their own anxiety or make themselves feel well without injuring their health. Sometimes with chronic illness, I'm just working with anxiety, depression, frustration, fear, and so it's just a direct, supportive, psychotherapeutic treatment. This is particularly true with cancer patients who feel they have a monster out of control and somehow their body's betrayed them. But I like to look at the chronic illness as a course correction, a signal that they need to make some changes, and use their illness as a teacher. Frequently, patients need support to get the support from their environment, be it from their families or their spouses or their friends, and especially with chronic illness when they have to ask for it more than once, or if there's a recurrence, or there's another flare-up, the diabetes. Somehow they feel they've spent their one wild card, and they're afraid to come and ask their family again for support or ask their friends to lend a hand when necessary. In particular, with regards to support, patients need to understand how to use their doctor, whether it be working with Bill or other doctors. I'm frequently saying to the patients, you're the one who knows what you need. Go with a list, go with a friend, don't be overwhelmed by the white coat, and tell the doctor how you need to be communicated, both in style and content. So in these ways, I try to help empower the patient to become an active participant in both their health and in their well-being.
It's very important, isn't it? Ladies and gentlemen, you just have just heard from our expert panelists sharing with us some very important information on the two different opposite aspects of medical care, the two ends of the same spectrum, if you will, the acute care in the emergency setting and the care of the chronic long-term illness such as cancer or hypertension. In the second half of our show, I'd like to have a few questions for our panelists. And the first question will be addressed to Dr. Mango. Dr. Mango, cost effectiveness is such a key word nowadays. We have to cut costs, you have to be really effective. And yet, as a specialty, emergency ranks so high on the hit list of the malpractice lawyers. So my concern is whether the practice behavior of the emergency physicians is being influenced constantly and to a significant extent by their fear of potential malpractice risks. What is your opinion on this issue?
Dr. Vu, I agree with you. I think emergency physicians are influenced constantly, specifically daily, in their practice of emergency medicine. I think part of the problem is that we can be held accountable, which is a good part, but in a sense an X-ray, that stays the same. It can be reproduced 5 years from now in a court or in a transmission of any kind of information and will be the same. Whereas a physician's clinical judgment 5 years from now can be very suspect, can be criticized, can be second-guessed, and therefore very few physicians today are willing to go with their clinical judgment without documenting it. For example, when I started to practice emergency medicine in 1965, a person came in with a dislocated finger. I'd diagnose it, that was obvious. I'd reduce it, I'd splint it, and I probably would not, unless I suspected that there was a clear evidence of a fracture, get an X-ray at all. I would refer that physician to the appropriate follow-up physician, and 3 or 4 days later, that second physician would decide whether we needed an X-ray or not, depending upon how it was progressing. Today, patient comes in with the same problem. You get an X-ray of the finger before reducing it, namely while it's still dislocated. You reduce it, splint it, and get another X-ray. The chances of there being a chip fracture in there it has to be documented, because sometimes in reducing the finger one gets a chip fracture. And if one doesn't have the pre-reduction film, one can always be held accountable that your reduction caused the fracture. So clinical judgment comes under attack, physicians get defensive, and they order a lot more X-rays, especially in the emergency setting where we don't have the benefit of rapport on a long-term basis. We try and get rapport, and that's 15, 20, 30 seconds sometimes. So the emergency setting is a high medical legal area these days. We like to think that it's not right, but that's the system, and we work with the system.
That's unfortunate that we pay such a high price because of the high expectation of the patients. It's a difficult issue. I agree with you. Dr. William Buckles, what are the criteria of a good doctor-patient rapport or relationship, and how does that play in effectively cutting the cost of medical care?
Well, Dr. Vu, I would say that the really good doctor-patient relationship is founded on 3 basic principles: that of communication, responsibility, and respect. That there needs to be a very clear communication, as Dr. Susan said, that both the doctor and the patient have to learn each other's styles, so that the doctor must speak that patient's particular dialect of body language. Similarly, patients may need to learn how the doctor communicates. The need for responsibility, meaning literally the ability to respond, is also very clear, with the doctor needing to be present, that he or she has to be there thinking about that patient rather than thinking about malpractice or golf game or a patient in the hospital or what have you. Similarly, the patient has to be responsible for their own health maintenance. That I think the health maintenance organization really starts with the patient. And finally, there needs to be respect, where the doctor sees the human being, and ideally it is an I-thou relationship, rather than the doctor looking at the disease, the disordered organ. And similarly, the patient respecting the doctor and not looking with hostility or mistrust. The best example of how this is cost effective deals directly with the malpractice issue, because patients who trust their doctors and have good communication, even if there has been negligence, don't sue as often.
That's true. That's so true. Dr. Susan Buckles, it is my observation that there are two aspects of the care, and both play very important roles in its quality. We have the technology. You have the best technology in the world. There's no question about it. But the communication part has something to be desired. What do you think we can do to help the healthcare providers improve their communicative skills with their patients?
Well, there has to be training. There has to be time and support for that, to remember their humanity and understand the effect they have as physicians on the patient. That patients are frequently intimidated by the white coat. Blood pressures go up, memories disappear, and the doctor has such power. They have to basically share that with the patient to encourage the patient to become involved. The patient, the physician must be trained in this, I think, partly because it's such a highly technical technologized care that they have to get the humanitarian training as well.
The doctor himself is scared too.
Scared to death.
So, we really have to respect each other in terms of helping each other in a team. That's great. Nowadays, Dr. Mango, a 5-year-old kid can perfectly master the use of a complex computer. I have a question for you about remote control medical practice. Do you foresee a time in the near future when a physician can effectively triage, diagnose, or even treat the patient with the help of a telephone and a television screen only?
The answer is yes, and that's been utilized for a fair number of years now, like 10 or 15 years in certain locations. I think the principle is that we should use technology prudently on a cost-effective basis. We should really utilize technology to optimize physicians who are particularly skilled in diagnoses, to be a resource to other physicians in remote areas. I've practiced emergency medicine in smaller communities where there is little or no backup, and that is the most difficult challenge of any place. It's easy to practice emergency medicine in a medical center where you've got 10 specialists deep, usually until 5 in the afternoon, then the depth decreases, but practicing medicine in rural America is where you need a real doctor, and we should utilize the technology that's available.
I would take issue a little bit with that. I don't think that in chronic illness you can replace the doctor-patient relationship without the contact. I know that when I am taking care of a terminally ill patient at home by telephone, that I only get a fraction of the information that I get when I make a house call. So that a house call, even though it is not, quote, cost-effective use of my time because of the travel involved, is very patient-effective because what needs to happen is not communicable through television or by voice alone. It has to be with presence.
I have a question about the preventative aspect of cancer. We all know that just by not smoking, the reduction of risk of having a lung cancer is drastically reduced. Is that true of other type of cancers? For example, if you exercise regularly, you eat a nutritionally balanced and healthy diet, and you don't smoke, you don't drink, does that improve your chance of not contracting cancers of other type like leukemias and things like that? I don't know whether that would play a role.
80% of cancer is preventable.
Really?
So there's a tremendous amount patients can do if they're educated and motivated and believe somehow that they can make a difference.
What a lot of people think is that the environment causes a lot of cancer. What's true is that external environment like industrial pollution is responsible for no more than 5 to 8%. A third of all cancers are due to tobacco, whether that is lung, head and neck, pancreas, bladder. A third of all cancers can be prevented by changes in diet. My advice to patients is shop in the produce department. That fins and feathers are fine, forget about the four-footed food. That animal fats, for example, are implicated in both breast, bowel, and prostate cancer. The Harvard study showed that if, in this case, men walked 8 miles a week, that their risk of dying from any disease, whether it be cardiovascular or cancer, was reduced by 15%. So it does work, lifestyle does work for prevention of cancers other than lung.
I see. That's very interesting. I have another question I'd like to ask Dr. Mango. One of the disturbing thing in medicine and in medical training for me is that it's so competitive. Physicians are highly competitive. It's a tremendous fight just to get into medical school. And throughout the whole training and education, it's really sometimes, you know, almost a barbaric experience in terms of, it's almost a cutthroat kind of a situation. And yet the teamwork is so important, especially in emergency medicine. How do we train physicians to be decisive, aggressive, and in control, and yet willing to work as a team member, to be flexible, to be patient, to be a diplomat at the same time? How do you train a physician to be a general and a diplomat at the same time in the emergency setting?
It's a very good question. I agree with you that I think that so much of medical training is dehumanizing and depersonalizing, and that it really is one of the few vestigial structures of serfdom and feudalism. I mean this seriously. I look at medical training as a form of child abuse, because the professors got beat up and abused by people when they were going through. They are just handing it down. Fatigue, since when does working 110 hours a week improve decision making? And who suffers? It's the patient that suffers. It's a macho, depersonalizing journey that doesn't have to be, and I think wrings a lot of compassion out of people, and really sets them out to go into practice when they're very tired, they're sleep deprived, and they're just angry for being beat up. Now, one of the strategies I've developed in recruiting physicians, I ask them if they've played on teams. I found that people that have played on teams know what winning is all about long before going to medical school and residency can take it out of them. So people that have played on teams have a sense of organizational development, so to speak. They understand that winning teams, if you watch winning teams, people on the sidelines when they're winning in the Super Bowl, they talk about loving each other. I mean, there's real respect and real trust and real sharing. So I don't know how that gets extrapolated into a more humanized medical training system, but I think the whole population, the whole society would benefit greatly by humanizing the way we train our healers. And we have to stop training technicians and go back to training doctors as healers.
I agree with you completely, and I think, Dr. Vu, that is perhaps one of the answers of training physicians in communication, is that it requires a rehumanization of the medical training process.
Yeah. Now, Dr. Buckles, I understand that you have very close contact with Stanford University, and one of the concerns that is often expressed nowadays that academic medicine is out of touch with reality. In other words, we're not taught the skills that we use every day in community practice. Can you just give us a short summary of how you feel about that?
One of the things that I anticipate doing is giving a course to the medical residents at Stanford. The director of medical residency works out at the gym with me, and we were talking about how to humanize the experience for the medical staff. And I would teach them about hope that they can communicate to their patients, and hope for the physician also, so that there is a greater understanding of what the human experience of illness is.
Thank you very much. It's so that we don't really become bookworms and just get so wrapped up into the research aspect of it. We should have more clinicians in the real sense of medical practice. We are sort of running out of time. It's really a pleasure to see you here, and I really appreciate your presence here. It is tremendous, and I hope that sometime in the future we'll come back to share some more experience and knowledge with us. It is really a tremendous satisfaction for me to have you coming here, and I really appreciate that. Ladies and gentlemen, you have just heard from our expert panelists on the two opposite and yet very important aspects of medical care, which are the acute care in the emergency setting, which was discussed to us by Dr. Carl Mangold, and the aspect of chronic illnesses such as hypertension, cancer, and so forth, is discussed to us by the team of Dr. William and Susan Buckles. On behalf of the production staff of America's Healthcare Crisis and Channel 30 Los Altos, Access Los Altos, I would like to extend my warm, sincere thanks to their taking time off to be here with us tonight. Again, our show is intended to be a forum to provide a forum for the expression of ideas that might help improving the efficiency of our healthcare delivery system. And we'll welcome any suggestion you might have for us. If you want to write to us, please use the address on the screen. If you want to suggest certain topics for us to cover or certain speakers for us to invite, please let us know. And for the schedule of future productions, please check the time and dates in your local newspapers. Again, I'm Dr. Hung Vu. Thanks for watching. Good night.
Thank you very much.
Thank you.
Thank you.
So we're wrapping up now.